A very good evening to all the participants of Rehabilitation Science YouTube channel. Today we have with us Dr. Gagan Kapoor with a very interesting topic on ACL injuries and rehabilitation. Dr. Gagan is a physiotherapist, and I must mention that he's a well-renowned sports physiotherapist in North India with his MPT in sports medicine and his BPT from the prestigious Institute of SV Nirtar, Cuttack. Presently, he is the director of Axio Prehab and principal consultant at Yash Physiotherapy and Sports Injury Clinic in Indirapuram, North India. Dr. Gagan has numerable contributions to the profession of sports physiotherapy in terms of his association with various sports, including cycling and football. With 20 plus years of experience, he is going to share his views on ACL injuries, repair, and rehabilitation. Thank you, Dr. Gagan, for being with us today and sharing your views.
Thanks a lot, Dr. Harpreet. And I thank Rehabilitation Science Group for inviting me here for today's webinar. So today's webinar is Return to Sports After ACL Injuries. Uh, I would like to thank Dr. Dharam Pandey, Dr. Shagun Agarwal, and Dr. Harpreet for introducing me here. This webinar will give some insights about how and when to return to sports after an ACL injury or reconstruction. So ACL is one of the very commonly injured ligament of the knee joint, especially in sports like football, and it is a non-contact injury basically, non-contact injury. And once this injury happens, there is only one question which is asked. The athlete asks, "When can I get back to my sport?" And the managers and the stakeholders, the coaches, they always ask, "When will my boy get back to sports?" So it is very important to understand when and how to return someone back to sports after ACL injuries. So why ACL reconstruction? ACL reconstruction is the current clinical standard for patients with an ACL tear and considered to be at a high risk of knee instability. So it is the management which is clinically considered as standard for patients with an ACL tear. What is the success of this procedure? The patient should be able to return to the same level of sporting activity as before the injury. So the criteria which is considered as the success is that the athlete should be able to return to the same level of sporting activity as before the injury. So what is the purpose of ACL reconstruction? The main purpose is to provide a mechanically stable knee joint. So as we all know that ACL is providing the stability to the knee joint, but once it is injured in an ACL deficient knee, there comes mechanical instability, and this can lead to recurrent injuries in the knee joint, which can damage other structures in the knee joint like cartilage or meniscus. Other purpose is to reduce the risk of subsequent injury to the menisci and the cartilage, which is very important to maintain the structure around the knee joint and the proper function of the knee joint. So it is important to improve the knee function and provide a functional knee which can participate in high level of activity. 65 to 88% of the ACL cases are able to return to sports within the first year. So here, when we say return to sports, this sports could be any sport, not his pre-injury level sport, pre-injury sport, but it can be any sport to which he returns within the first year. It is fair to state that surgery is effective in allowing injured athlete to resume his sporting career. In a review, it was shown that 88% of patients return to sports, while 55% return to competitive levels after ACL injuries. So these results generally show us that though there is a level of participation by 88%, but to the previous level of competition, only 55% can come back to that level, which is one of the challenges of ACL reconstruction. So in one of the previous guidelines from 2004, it was seen that re-injury rate after surgery is there is 12% re-rupture rate found. There is 22% of the non-operative play-treated players who returned to sport underwent additional surgery for an injured meniscus compared to 12% operatively treated players. And it is found that 50% of second ACL re-injury rate with 7% of ipsilateral ACL and 8% for contralateral ACL. The more the delay in the time to return to sports, the poorer is the patient motivation and the psychological readiness, which decreases the chances of return to sports at the same level. But on the other hand, an early return to sport exposes the patient to a high risk of re-injury. So it should be optimized. The return to sport should be optimized, considering that if there is a delay, then the motivation level goes down and the return to sport at the previous level of competition also reduces. On the other hand, if it is too early, then it exposes the patient to high risk of re-injury. A history of ACL reconstruction is a big risk factor for developing a repeat hamstring strain, hindering return to sports and the future practice of sports. So while we are planning return to sports, we have to consider all these things. In the recent review, it was shown that 80% of people returned to some sport as compared to the previous report of 88%, and 65% returned to the pre-injury sports, and only 55% returned to the competitive sports. So once an ACL is injured, what are the management options? What are the options for clinical management? So both the options are there, conservative management as well as surgical. Conservative management is considered in few cases. The criteria of conservative management would be partial tears and no instability symptoms. There should not be any instability experienced by the patient, and if there are partial tears, then conservative management could be the treatment of choice. Complete tears with no symptoms of knee instability during low demand sports. So instability comes out to be a very important factor while considering whether the patient has to go for conservative management or for surgical management. For people who are involved in light manual work or have sedentary lifestyle, for them also conservative management can be considered. And in children whose growth plates are still open, conservative management could be the option. So usually conservative management is for 3 months or more, and progressive physical therapy and rehab is done in these cases. So the other option is the surgical management. For that, the prehab is the option. There, first of all, the person has to undergo prehab. So in which the aim and objective of the prehab is to attain full range of motion. Attaining a full range of motion is very important for proper function of the knee joint. And if it is gained, then it is seen that the post-operative results are better in cases in which full range of motion is achieved. There should be minimal joint swelling, a good strength. There should be adequate strength around the hamstring and quadriceps muscles. If during the prehab there is good strength available in the hamstring and quadriceps muscle, then post-operative results are better in those cases. There should be adequate neuromuscular control and a positive state of mind. And during the rehab after surgery, there are these considerations which are very, very important, like the range of motion and flexibility. The range of motion of the knee joint should be achieved as early as possible, especially the extension at the knee joint. Extension of the knee joint should be achieved early with a flexed knee, or in case of inhibition of the VMO muscle, when there is extension lag, then in those cases, getting a good gait or a normal gait becomes very difficult. So it is imperative to achieve good range of motion and flexibility early in rehab. Gait retraining, proper pattern should be followed so that once he returns to more strenuous activities like running and jumping, he has enough control and proper gait. So gait retraining is an important component. Muscle strength and endurance training, the strength of the muscles around the hip joint, around the knee joint should be good, and endurance should be training should be done to maintain the cardiorespiratory status of the athlete. Open and closed kinetic chain exercises. Closed kinetic chain exercises are followed initially in the rehab, and then open chain exercises. The proprioceptive training is also an important component. Restoration of full range of motion early, and restoration full range of motion is important. So, attaining full knee extension as soon as possible after the surgery. So it is very challenging at the initial stages because of the swelling of the surgical trauma and because of pain. Full extension is not present. There is inhibition of the VMO muscle, and the patellar mobility is also not good, because of which it is difficult to attain full extension. But with the help of patellar mobilization, with the help of, in some cases, biofeedback and activation of VMO, full knee extension, full active knee extension should be achieved. Then maintaining muscle flexibility with stretching, usually 30-second stretch for quadriceps muscle. The tone of the quadriceps muscle or tightness of the quadriceps muscles can restrict the flexion of the knee joint. So, and the hamstring muscle flexibility should also be maintained. Usually, full range of motion is gained between 6 to 9 weeks post-operatively. So, from about 1.5 to 2 months time, full range of motion is achieved in the knee joint after ACL reconstruction. So, altered gait typical in the first phase of rehabilitation. Early weight bearing to restore gait should be encouraged. People should be encouraged to weight bear early in the rehabilitation and maintain knee joint range of motion, adequate motion to provide good gait, to provide a normal gait cycle should be achieved, and there should be no pain after the first phase. So muscle strength and endurance, as we discussed, quadriceps strength, vastus medialis activation, hamstring strength, hip abductor and external rotator strength should be maintained. So in the rehabilitation, the progression should be according to the readiness for the next phase of the rehabilitation. Observe for the quality of exercises, and because if the weaknesses are there, they lead to compensations. They lead to compensation at the other level, and compensation lead to faulty movement patterns, which could lead to either injury to other muscles and joints, or could lead to overuse injuries. So right activation of the muscles at the right time is very important for proper control at the knee joint. As we can see in these uh, photographs, in these pictures, that the stability around the hip and pelvis is very important. As you can see in the first image, there is a hip drop when someone is stepping down on the side, and there is a valgus, a functional valgus is there in the knee joint, which predisposes strain on the ACL as well as the knee joint. So good stable hip musculature, good strength around the hip musculature to provide a stable base for jumping, landing activities is very important. And now with new technology and machines, it is also possible uh, to measure these angles and have an idea about the functional valgus if that is present. So neuromuscular and proprioceptive training is initiated immediately after injury. Post-operatively, proprioception training should commence early, should continue in the later stage. So as you can see, like we can use a wobble board, we can use first of all, uh, means use both legs to stand over the balance disc or wobble board, and then maybe single leg, and then some catching throwing activities over these, as you can see in the Bosu ball. So these activities could be catch and throw in the line of the body, and then maybe moving it outside, maybe down or up or sideways while catching and throwing, and improving the neuromuscular and proprioceptive sense. So stability exercises are important. Now, whenever we are dealing with the rehabilitation, first of all, we need to correct deviations and decrease pain, then achieve flexibility and range of motion. This pyramid is very important when we are looking at the overall performance of an athlete. So correct the deviations and reduce pain, improve flexibility and range of motion, improve strength and overall endurance in the form of cardiovascular, cardiorespiratory endurance, improve balance, coordination, and agility, which further improves the function and the performance. So, from the 2016 consensus statement on return to sport, the return to sport has been classified into three main parts, like return to participation, return to sport, and return to performance. It is important to understand this. Once an injury has happened and there is a recovery which is happening, first of all, the athlete returns to participation. Athlete can train, but he is not yet ready to return to sport. So there are certain sport specific activities which can further, training him with those sport specific activities can lead him to return to sports. So he can train but is not yet ready to return to sports. And at the next level, he can return to sports. The athlete returns to sport but is not yet performing at his desired performance level. So there is participation, but still he is not participating at the top level, at the level he used to perform earlier, or at the desired performance level. And then there is return to performance. Return to performance is where athlete return to its sports and is performing at or above his or her pre-injury level. So here it becomes very important when we are planning that we have achieved full range of motion, there is no pain, there is no swelling, then there is strength, there is the endurance is building up, all those things are there. Now the athlete needs to participate into certain activities which lead him to participate in the sport. So we need to plan out those sport specific activities, which could be in form of some agility drills, which could be in form of some sport specific running or jumping or landing activities. And after, once he has gone through it and he's much confident about it, then there should be return to sport at the lower level of performance, which could be with a lower level of opponent performing in the sport, or so that he does not strain himself too much, and then further he moves on to improving his performance. It takes time to return to performance after ACL reconstruction. We'll see that later in the slides. So there should be good uh, communication between the stakeholders like the athlete, medical staff, and the coaching staff, so that they collaborate in order to decide when the athlete is ready to progress to the next phase. So these phases are important. The clinical test and patient reported outcome measure should be performed to move to the next level. Workload may be linked to re-injury and should be monitored. Biological, psychological readiness should always be considered. Okay. So return to sports is decision making and should emphasize a graded criteria based progression that is applicable for any sport and aligned with individual return to sport goals. So as we discussed, the sport specific training should be there around 4 to 6 months post operatively. Usually in normal circumstances, it starts at around 4 months to 6 months post operatively. Agility drills for timing and speed, running first in the straight line, and then non-linear activities like cutting and pivoting can be introduced for sport specific training. It all depends upon the kind of sport the person is in. So as I've been with football for a long time, so these are the examples from football. But if someone is in wrestling or other sports, then he should start training himself at a lower level to to move to the next level of return to sports. So jump training and plyometric training and mini trampoline activities can be added in this phase. So generally, return to sports, there should be a gradual return to sports, maybe 6 to 9 months or longer. There should be no pain after sports specific training, no swelling after sports specific training, full or near full range of motion at the knee joint, and there should be appropriate strength and endurance. The functional test should be around 90% of the uninjured side. So, what are the factors that are associated with returning or not returning to sport? As we have seen that only 55% of ACL reconstruction cases reach the competitive sports. So there are factors which are related for with returning or not returning to sports. Younger age group with less than 20 years has increased risk of ACL graft ruptures, but there is an early participation of this age group. They usually participate back in the sport, and that again puts them at the risk of having another ACL injury. But still, they return to sports. Younger age group returns to sports early. The absence of concomitant or full thickness cartilage injury. If there is a cartilage injury, then the returning to sports become difficult. But without a cartilage injury, it is seen that more people participate or get back to sports. Professional athletes are these 2 points. Professional athletes and psychological readiness are somewhat related, but it has been seen that professional or elite level athletes, they return back to sports more often. In a study, it was seen that 81% of the professional athletes, they return back to pre-injury competitive status. The symmetrical knee function is achieved. If the symmetrical knee function is achieved, then there is more participation in the participation in the sports. And the close follow-up and high quality sports physiotherapy is also one of the factors for returning to sports. So in the gender, male gender is seen to getting re-injured more often after returning to sports. Early or younger age group, though they participate more in the sport, they participate back in the sport, but still it is seen that the re-injury risk is higher in the early age group, on the younger age group. Then the activity level, with higher level of activity, there is a chance of getting it re-injured. Graft placement, graft type, and time of surgery are important factors which can lead to re-injury. Deficits in the neuromuscular and biomechanical control are also one of the factors for re-injury. Clinical studies use many techniques and criteria to determine the optimal movement for a return to sports after ACL reconstruction. The most used is the post-operative timeline, as we see that after ACL reconstruction, the ACL, the graft that goes through a process called ligamentization, and the ACL strength, as you can see here, the strength of the ACL graft when it was reconstructed and at about 3 to 4 months time reduces. The strength of the, because of the healing process, the graft strength reduces, and again it starts gaining strength at around 5 months, 4 to 5 months of post-operative time, and it comes down to original strength at about 9 months. So the most used post-operative timeline, which is related to the healing or ligamentization process which is going on in the knee joint, is either alone. So it could be the post-operative timeline either alone or with muscle strength. Knee laxity as tested by KT 1000 or KT 2000, and muscle strength testing done by either isokinetic dynamometry, the knee assessment form, patient reported outcome measures like IKDC are used, or functional tests like lower limb symmetry index is used to to see the criteria for return to sports after ACL. A delayed return to sports from 6 months after surgery to 9 months after surgery decreased the risk of re-injury by 51% each month RTS is delayed. So after 6 months of surgery, if there is a further delay doing the rehabilitation, then the risk of re-injury reduces drastically. So now earlier there were accelerated programs which used to make a person reach to sport return to sports at 6 months post-operatively, but now it is seen to prevent re-injury uh, and corresponding healing or ligamentization process which is happening, the return to sports should be at around 6 to 9 months, which prevents further injury to the knee joint. So when should athletes return? There are issues which prevent them from returning to sports, which is graft rupture or failure. The period of remodeling is between 4 to 12 months time point, which also corresponds to the time when many athletes return to sports. So we have to be careful out here. Hamstring tendon autografts may take 12 to 24 months in remodeling. So another review, it was seen that hamstring tendon autografts were more re-injured as compared to patellar tendon bone grafts. So returning to sport puts individual at risk of both ACL graft rupture and rupture of the contralateral ACL. So during the rehab, when we are planning return to sport activities or rehabilitation, we should also consider increasing the strength, endurance, balance, and agility of the contralateral side, because in most cases there is a chance of injury to the contralateral ACL. Risk of graft rupture is highest during the first 2 years post-operatively, whereas the risk of contralateral ACL injury appears to occur relatively later. Younger athletes are at significant higher risk for second ACL injury. Between 20 to 30% of younger athletes sustain a second ACL injury. 27% of patients less than 25 years at the time of revision ACL injury surgery go on to have a third injury also. So the younger age group, it is very, very important for us to see that they undergo very good rehabilitation and should not be rushed into return to sports. So return to sports criteria, as we discussed, it is phased rehab program with set criteria for progression. This contrasts with the time-based model. So the return to sports criteria should be phased in the rehab program with set criteria for progression, and use set or criteria or test battery to clear athlete to return to sports. These tests are, as we discussed, the strength test, the hop test, limb symmetry index, which should be 90% of the uninjured leg, and the measurement of the quality of movement. Quality of movement should be good. Now, along with the quantity, the quality is also important in such cases. The quality of running, the quality of landing, the quality of agility drills, all those, the quality is very important. So high proportion, 70 to 80% return to sport after first reconstruction procedure. The rates drop dramatically to less than half after a second reconstruction. And return to sport among elite are higher, 83% after first ACL reconstruction and 71% after second ACL injury. This is one of the very famous case studies where a 35-year-old forward player sustained an isolated complete tear of the ACL, and this happened when the World Cup was 134 days away only. So ACL reconstruction surgery was performed 4 days after injury with double loop semitendinous and gracilis autograft, and a progressive rehabilitation program allowed the patient to play for 20 minutes in the first division game 77 days after the surgery. So this was an exceptional study which was published in JOS PT in 2005, in which this player, very famous player, Roberto Baggio, he came back to the first division soccer game 77 days after surgery, and played a full game 90 days from surgery, which is 3 months. So this is a case study in itself, but this is probably an exceptional case study. So factors that may have favored early return are optimal physical fitness before surgery. He was already playing in the season and he had a good physical fitness before surgery, strong psychological determination. So these days a lot of studies are being done on the psychological aspect of return to sports after ACL injury. It is seen that players who are more determined and are psychologically, they are carrying a very, very positive attitude after ACL surgery, there is a good chance of their returning to previous level of sports early. So this guy had a very strong psychological determination, and it was an isolated lesion only. So these factors are also very important when the return to sports is considered. So this was an isolated ACL injury. There was no meniscus damage, no cartilage injury along with it, and the graft was properly placed and tensioned. So which is a surgical aspect. So the high level of surgery with proper graft tension and placement is important, and personalized progression of volume and intensity of exercise load. So this was done by Del Villa, who is also part of the isokinetic group, and they followed the system of traffic signal light, where red, orange, and green are like the traffic signal lights. And if there was some problem, say there was pain or there was swelling during the rehab, then they went one step back. But as long as the body was able to take progressive rehabilitation, it was followed. So personalized progression of volume and intensity was followed of exercise load for early return to sports. So the take-home message: surgical and non-surgical options are available for ACL injuries. Choice to be considered: understanding benefits of one over the other. A graduated rehabilitation program helps improve the outcomes after surgery. Sport-specific training is important component of rehabilitation. Criteria for return to sports needs to be followed, which could be in form of strength tests, in the form of hop tests, or functional tests. And prevention of ACL re-injury is important even after a good rehabilitation. So thank you very much. Thank all of you, and I thank the Rehabilitation Science Group again for inviting me here for this talk.
Uh, Thank you, Dr. Gagan. It was a wonderful presentation and covering all aspects of ACL injury in terms of conservative management and post-surgical repair. Dr. Gagan, although it seems very clear that some sports are more prone for getting the ACL injuries. So, Dr. Gagan, is there any difference between the dominant and the non-dominant leg getting ACL injuries?
So as we know, it is a non-contact injury. Okay, so it is usually an injury which is sustained during the fall or twisting injuries. So it is a landing injury basically.
Yes.
So it can happen in any of the limbs. It can happen in dominant or non-dominant limb, and it is also seen that in about 50% of the cases, if someone has sustained an injury on one side, then there's a chance that contralateral ACL also gets injured if the person is participating in the sports. So not as such uh, there is dominance is not the criteria considering the injury which is happening in the ACL.
Right. Uh, Dr. Kagan, and what about the gender? I think you mentioned somewhere that male athletes are more prone. So
No, they
there
look.
were two questions on it.
Yeah.
One was like, which gender is more prone, and the reason for that? And is there any way that we can identify and prevent ACL injury from happening?
So female is the gender which gets more ACL injuries because of the anatomical structure of the female body, the wider pelvis, the smaller notch, the intertrochanteric notch, and the strength of the ACL ligament itself. So females are affected more. But the point that I mentioned in the presentation was the re-injury is seen more in the male participation.
Right, right. Yes.
So re-injury rates are higher among males, but generally females get more are more prone to ACL injuries.
Yes. Thank you, Dr. Gagan, for joining us today and sharing this wonderful piece of information.